Hello, and welcome to another episode of Hematology Horizons. My name is Elissa Baldwin, and I'm the Director of National Patient Education at the Leukemia and Lymphoma Society. Today, we have a very special episode and are taking you on site at the ASH annual meeting, presented by the American Society of Hematology. This meeting is attended by around 30,000 healthcare professionals from around the world to share the latest research in hematology. I am here to take you around the conference and to talk to researchers and LLS staff and hear the highlights in research that benefit blood cancer patients and their loved ones. Let's go check it out.
Hi, Andy Kolb, President and CEO of the Leukemia and Lymphoma Society. I'm joining you from ASH today. It's been an amazing conference this year in beautiful San Diego, and I'm just excited to see all the incredible work submitted and presented by LLS-funded investigators. We have made a big splash at ASH again this year, and it just shows the incredible progress that we're making. LLS has been funding breakthroughs in blood cancer research for 75 years, and this year is no exception. It's fun to see the great work that's being done and fun to think about what that's going to mean for patients and families in the future. And this is the first year we're seeing publications from our Equity and Access research program. The first 3 abstracts from that program are presented this year at ASH, and it highlights the fact that discovery is only half the battle. We have to make sure that patients have access to care. So we showed up in a big way in Equity and Access, and it's great to see those scientists here presenting as well.
I'm Sharon Castellino, and I am a pediatric oncologist at the Aflac Cancer and Blood Disorders Center, Children's Healthcare of Atlanta, and Emory University. It's been great today to be a pediatric oncologist at the plenary session where the amazing results of the Children's Oncology Group 1731, ALL 1731 trial were presented. This trial represents a huge move forward for pediatric acute lymphoblastic leukemia, ALL, which is our most common blood cancer in the clinic. The benefit of adding the BiTE therapy called blinatumomab has created a dramatic increase in disease-free survival for children with standard risk acute lymphoblastic leukemia. I think that this novel therapy is really going to help us to move the needle and in the future look at how we may be able to then decrease some of the conventional chemotherapies which have been successful in curing ALL in children but have often left them with late effects. And are pretty difficult to tolerate in the short term, when they go through therapy. So this is a huge step forward for children with ALL, and it's an exciting movement, especially as these agents had been moved forward in the adult setting a few years ago, and the fact that we have been able to see the results of this trial in pretty short order since the adult cooperative groups reported their results is also promising in terms of the timelines that are sometimes challenging for moving novel therapies into children.
One of the things I was really excited to see this year at ASH are the results of the blinatumomab trial in children. It showed a 7% improvement in overall survival. That's going to translate into a lot of life years that are saved, a lot of life years that are gained, and it's incredible work. But it is a drug that is expensive and very hard to deliver. And we have had our patient services team has been leading the way on making sure that patients have access to that drug because it will make a big difference for children.
My name is Tina Bhatnagar. I'm the Medical Director of Hematology Oncology at West Virginia University Cancer Institute Wheeling Hospital, and I'm also an Associate Professor of Medicine with an interest in blood cancers. I think the most exciting thing when it comes to CML or chronic myeloid leukemia this year is that we have a new kid on the block in terms of a new treatment option that's available for patients. There's a drug called asciminib, which has a little bit of a different mechanism of action than the drugs that we normally use to treat CML, and it already has approval in later lines of therapy, but there was some really exciting data here at ASH showing that it's excellent as a frontline agent or as the first line of therapy in newly diagnosed CML patients as well. It has a great side effect profile, which we were all really excited to see because one of the biggest things that we struggle with when we're treating people with CML is side effects when they're starting some of their drugs. And so the safety and the side effect profile of asciminib seems to be quite a bit better than the traditional medications that we use to treat CML, and the responses are great and durable. So for me, I think it may potentially change my practice pattern moving forward, and will probably also change the way the patients feel when they're starting treatment for CML.
My name is Laura Gruenbaum, and I'm the Chief Scientific Officer here at the Leukemia Lymphoma Society. And at this year's ASH, I'm particularly excited about a new class of drugs that have just started to become available for patients with the very first FDA approval. These are called menin inhibitors, and they are drugs that target a particular type of acute myeloid leukemia, which of course is a disease that still has a very poor prognosis for many patients. And I'm really excited because LLS has supported the basic research that actually led to the mechanistic understanding that this mechanism plays for AML. In the 1980s, we have continued through grant funding and then through our therapeutic acceleration program to actually fund the development of one of the two leading drug candidates. And we have then continued to work with companies that are developing these drugs further, including the first approval, and made sure that these drugs are now also being studied. And I should say these are clinical candidates, again, in the case of one of them, in the Beat AML study with our Beat AML team. This is a combination study for elderly patients who are newly diagnosed, as well as in our PEDAL trial as a option for precision medicine for certain pediatric patients. So I think this really illustrates the impact that LLS, our research funding, and the many, many facets of it can have on the really generation of a new area, a new type of drug where we're going to see many, many more presentations and many, many more wonderful applications for patients.
Hi, I'm Ailey Chair. I'm a physician scientist at Oregon Health Sciences University in Portland, Oregon. Here to talk a little bit about the things that we've seen at ASH this year. And there are a lot of exciting things at ASH, always are, more than I can even keep up with, so I won't cover everything. But it's hard not to ignore a lot of the talks this year on menin inhibitors and AML, which is my clinical and research specialty. In fact, there was a whole session devoted to menin inhibitors and the different menin inhibitors. But it's good news because it's actually an agent that seems to have quite a bit of activity, and now we have multiple drugs that are targeting the pathway. And even though it has single agent activity and a sort of a limited number of patients who are relapsed and refractory, the numbers that we've seen here, where we're combining it with chemotherapy and either intensive chemotherapy like 7 and 3, or with venetoclax and azacitidine, we're seeing remarkable response rates that are very encouraging. So we'll see how long and durable those responses are, but what's very nice to see is that we're really starting to see a lot of activity, and I think in the broader perspective, we're seeing targeted agents being combined with upfront therapy, and really we're taking advantage of those and improving upon the responses, and we're seeing nice responses in many patients. So very exciting to see more of that data. We're just waiting more clinical data, of course, and long-term follow-up. We're also getting more of an appreciation for the AML cells themselves and actually what's driving resistance. For a long time we were really focused on mutations and how that drove resistance to therapies. And now there's an understanding that there's mutations and this cell state, sort of the different types of AML cells that can exist in a patient. And they can be more primitive or more mature, and that seems to drive a lot of relapse. And in fact, that's a lot of what we're doing in the lab ourselves, is trying to understand how those two things cooperate together to drive resistance to therapies.
Hi, I'm Dr. Matt Matasar. I'm the Chief of Blood Disorders at the Rutgers Cancer Institute in partnership with RWJ Barnabas Health. And I'm here at the 66th Annual ASH Conference in sunny San Diego to share with you some of the most important new updates in our understanding of how best to take care of patients with non-Hodgkin lymphoma. Some work that I've helped lead is evaluating how we can best take care of patients with aggressive B-cell lymphoma who've been failed by CAR T-cell therapy. And we know that CAR T-cell therapy is powerful and can cure even as many as a third of patients with relapsed disease, meaning disease that's come back after good initial chemotherapy. Unfortunately, CAR does not cure everybody, and we need to do better at taking care of patients when they've been failed by CAR. To that end, we've studied the use of a different type of immunotherapy called bispecific antibody therapy, and a medicine specifically called odronextamab, which just rolls off the tongue. And we looked at using odronextamab in patients who've been failed by CAR T-cell therapy and found very encouraging results. Half of patients treated with this new medicine will have their disease shrink or go away, and a third of them will have it disappear entirely. This is true especially when CAR T-cell therapy has worked but not well enough. When the disease comes back 6 months, 12 months, or even later, odronextamab is very likely to help patients' disease shrink or disappear. We also found that the medicine is relatively safe. There are some inflammatory reactions that can happen, but they're very brief, and doctors are increasingly good at managing these risks. So this may paint a way forward for us in the field in terms of how we can best optimize outcomes and how best take care of patients after they've diseases come back after CAR T-cell therapy. For slow-growing lymphomas, we've also seen some very encouraging data for this class of medicines, this bispecific antibody class. And we here present some data for a new bispecific antibody. The ones that are currently approved, odronextamab, which is approved in Europe, mosunetuzumab, glofitamab, epcoritamab, these names are amazing, all approved in America for the treatment of various forms of B-cell lymphoma. They all target a protein on the surface of lymphoma cells called CD20. But sometimes when you've treated with medicines like that, CD20 can disappear, and these medicines are not effective when that happens. There's a medicine that we've tested with the fancy name of AZD0486, which targets not CD20, but its brother, CD19. And particularly for patients with slower growing forms of lymphoma, like follicular lymphoma, this new bispecific antibody therapy is very effective, with 9 out of 10 patients having their disease shrink away, and 8 out of 10 having it disappear on scans. This is very early research, this is not approved, but it really is encouraging findings that's going to lead us to do more studies and work on trying to bring this drug to more of our patients to take care of their illnesses.
Hi, I'm Swati Goyal. I'm one of the hematologists at Montefiore Einstein Comprehensive Cancer Center in Bronx, New York. I'm really excited to discuss some of the recent research updates with you in the field of myeloproliferative neoplasms here at ASH 2024. There have been some exciting studies which have been resulted in this conference. One of the studies I'm really excited about is a newer line of therapy called cell therapy in myelofibrosis and other myeloproliferative diseases. One of the products is called T regulatory cells. So myelofibrosis is a disease which has high inflammation state in the body, and these T regulatory cells, which are off-the-shelf T cells, can be infused in a patient in the clinic setting with almost no side effects, and it helps calm the inflammatory storm in the body. The other study which touches upon the cell therapy is in preclinical stages. That means it's not yet studied in patients, but the proof of concept with CAR T cells against CALR molecule, which is often mutated or changed in myeloproliferative neoplasms, has been discussed in this ASH conference. CALR molecule, again, is often mutated in myeloproliferative neoplasms, and the CAR T cells, which are T cytotoxic cells against this mutation, helps in treating this disease. The other therapies which have come to light in this conference are something called oral MDM2 inhibitor. The results of the Boreas trial were discussed in this conference, which showed that the MDM2 oral inhibitor seems to be highly effective in myeloproliferative neoplasms. And going forward, there's a trial with combination with JAK inhibitor called POISES trial, which will start enrolling patients soon. Other preclinical studies which were discussed in this conference touch upon newer therapeutic targets like ROCK target, PPM1D target, and PIM1 kinase inhibitor. Again, these new targets give us opportunities to target these myeloproliferative neoplasms in different ways. It's not that one therapy is effective against everyone, so we need different therapeutic targets, we need different strategies to help overcome these diseases. The role of P53 mutation has come to light, which shows that the patients who have P53 mutation can often have bad prognosis compared to the patients who don't have P53 mutation. There were various studies which showed us that if the patient has high P53 mutation burden, meaning many cells have that P53 mutation, then transplantation or other aggressive therapies need to be instituted early on.
Hi, I'm Ola Landgren. I'm professor of medicine and I'm chief of the Myeloma division and the Myeloma Research Institute at the University of Miami Sylvester Comprehensive Cancer Center in Miami, Florida. I'm here at ASH 2024 in San Diego, and there is a lot of new information on multiple myeloma here. I'm very excited about all the new developments in every aspect of the disease. We hear from precursor disease to newly diagnosed to patients with relapse refractory multiple myeloma. What really excites me this year is how much focus there is in the newly diagnosed setting. I pioneered over 15 years ago work on minimal residual disease, MRD, when I worked at the NIH in Bethesda, Maryland. And the work I have done has been to test the hypothesis that if you can measure MRD about a year after randomization on a clinical trial and you see a higher rate of MRD negativity on the experimental arm, the new therapy control compared to the control arm, that you can predict that that new experimental new therapy will deliver a longer progression-free survival many years into the future compared to the control arm. The FDA uses progression-free survival as the measure for success. So if you open a trial and you don't have MRD as a tool, you have to wait for the data to mature. So that means that a new medicine that's developed, say for the newly diagnosed myeloma setting, you start a trial, you randomize between the new therapy and the control arm, but you have to wait for 10, 15 years for the data to be ready to be assessed. Again, if you can check for minimal residual disease detection or MRD detection after 1 year post the randomization, and you see there is a much higher number of patients that are MRD negative for the new therapy, you know that that is going to lead to longer progression-free survival. And I was able to convince the FDA and the ODAC committee, the Oncology Drug Advisory Committee for the FDA, to consider this as an early endpoint for accelerated approval. The ODAC voted in April of 2024, 12-0 in favor of MRD negativity. Here at ASH, I talked to so many individuals I've known for a long time in different drug and pharma companies, and they all tell me that now they're implementing MRD as a tool for drug development. That means that there will be drugs developed much, much faster. So instead of waiting for 10 to 15 years, we can get drugs approved in 1 or 2 or 3 years from starting studies. And if those trials read out successfully, patients can get access to these new therapies. That really, really excites me. And I think with an endpoint like that, there is much more appetite from the drug companies to develop trials that are intentionally designed to seek a cure for the disease, which is a huge step forward for us. I also, along those lines, here at the meeting, see how the trials that are already ongoing, how they have pushed the envelope for the new immunotherapies. And there are a lot of chemotherapy-free regimens that are already available, and you can give them to a young, fit, newly diagnosed myeloma patient. You can also give them to someone who is slightly older or someone who has comorbidities. And if you look and see how multiple myeloma happens in the general population. We know in America, the age of onset, the median age of onset is around 70 years. 95% of patients are 50 years or older. So if you split that group from 50 years or older, about half are from 50 to 70 and half are 70 and up. About 5% of all patients are diagnosed before the age of 50. But a large proportion, as you just heard me saying, are diagnosed at the age of 70 or older. And if you give the new therapies we have, you can, in a very high proportion of patients, see that the survival rate is 10 or 20 plus years. And if we now compare this to the lifespan for a human being, and if you look in the statistics for the United States, I think we have come to a point where we can tell many patients, we cannot guarantee, we cannot promise you, but it's very likely that you will have the same lifespan as an individual with the same age and gender without multiple myeloma. And that is really a huge step forward. We will continue to work to develop fully curative treatments. So what I was talking about are more functional cures where you can hold the disease away. You may have to come for injections maybe once a month or stay on some tablets long term. Ideally, we would like to develop those treatments that could be completely definitively curative. And that's what we are working on. And that's why the work on MOD we have done for a long time is so important.
Hi, so I'm Dr. Gwen Nichols. I'm the Chief Medical Officer at LLS, and I'm here in San Diego at the 66th Annual ASH meeting, American Society of Hematology. And the conference has been great. The area that I've been paying attention to relates to both the longer follow-up for CAR T-cell therapy. The commercially available products now have 5-year and beyond follow-up, and then also looking at the new types of cellular therapy and what I call CAR T 2.0, which may be allogeneic CAR, all kinds of new innovations with CAR. The most interesting follow-up that I've seen relates to some of the data in lymphoma. So lymphoma, we know that somewhere around 40 to 50% of patients get, who've had multiple relapses, get a good response with CAR T-cell therapy. So now we're looking at those patients. How long does that last? And the good news is that for responders, out at 5 years and beyond, 60-70% of patients stay in remission. So we're seeing people where it looks like CAR T-cell therapy really may be curative, and that is incredible given that the earliest people who got CAR T were multiply relapsed patients with really no other options. So that data is really promising. So the fact that we don't cure everyone with CAR T leads me to what the other piece of what I've been watching at this ASH meeting, and that is what are the innovations in the cellular therapy space and where are we going in the future? One of the things that I think is really important is looking at the immune environment, trying to understand why some patients get a great response and other patients don't. And part of that is, patients physically and on scans look exactly the same. So there are inherent immune differences between patients, and we have to understand that better, both so we can pick the people who don't need additional therapy, and also maybe those are the patients we should treat with CAR T plus or a more powerful cellular therapy that we need to enhance the immune system. So there are really a lot of primarily posters, very early work looking at different ways to make CAR Ts and how to make them faster. They talk about vein to vein time, and there are now therapies that can be made on site that can only be a few days, and some very exciting new therapy about putting cells in where you inject the CAR and the virus infects the correct cells in your body, not external to your body. All of these are ways that we can simplify CAR T, make it less cumbersome, and also make sure that patients don't have to wait weeks and weeks for the product to be made. Are these going to be ready tomorrow? No, no, they're not. But the possibilities that we can improve, even with the commercially available CAR Ts, how we administer this, I hope means that we can get it to more of the people who could benefit from it. And finally, there's some very interesting work looking at access and what we need to do to try and make sure that people who don't live near big centers can still have the benefit of cellular therapies. So lots of exciting work in the CAR T space.
Wow, what an amazing weekend. We have now heard about incredible new research for many different blood cancers and what LLS is doing to drive that research forward and create a world of more survivors. There is so much hope on the horizon for blood cancer patients and their families. If you would like to see even more on the research that came out of ASH, be sure to check out the LLS blog at the link below. Thank you for joining us. We'll see you on the next episode of Hematology Horizons. Take care.